Good evening. I'm psychiatrist Jay Fawver, live from Fort Wayne, Indiana. Welcome to Matters of the Mind. Now, in its 26th year, Matters of the Mind is a live call-in program where you have the chance to choose the topic for discussion. So if you have any questions concerning mental health issues, give me a call in the Fort Wayne area by dialing 969-2720, or if you're calling long distance, you can dial toll-free at 866-969-2720. Now, on a fairly regular basis, we are broadcasting live every Monday night from our spectacular PBS Fort Wayne studios, which lie in the shadows of the Purdue Fort Wayne campus. And if you'd like to contact me with an email question that I can answer on the air, you may write me via the internet at Matters of the Mind, all one word, at wfwa.org. That's Matters of the Mind at wfwa.org. And I'll start tonight's program with a question I recently received. It reads, Dear Dr. Fawver, is it harder to quit smoking when you have other health struggles, or is it just as well to tackle smoking and whatever else you are challenged with? Well, I'm going to presume you're talking about tobacco smoking, so we'll start with that. Tobacco smoking releases nicotine, and that's the pleasurable chemical that people are attempting to use to achieve a good feeling. And with tobacco smoking at the nicotine, you're getting increases in dopamine in the brain. To some degree, you're getting norepinephrine effect. You're getting a muscle relaxant effect, but the whole idea behind nicotine, people can get a bit of an antidepressant effect, and they can improve their concentration to some degree. So people will use nicotine as a means of feeling good and helping with depression. So when somebody's struggling with stopping nicotine, we often have to sort out what part of the struggle is nicotine withdrawal, which will make you feel terrible in itself, versus losing the good effect that nicotine was giving you. And for that reason, years ago, there was a medication by the name of Wellbutrin that was studied for the purpose of offsetting the antidepressant effect of nicotine, because Wellbutrin, also known as bupropion, came out in 1989. It's been available since. It's used to increase norepinephrine and dopamine to some degree. That's what nicotine will do. It'll increase norepinephrine and dopamine, and in doing so, improve your concentration and sometimes improve the mood. So Wellbutrin was studied as a means of helping people get off of nicotine. It had a trade name at the time called Zyban. So Wellbutrin, also known as Zyban, which are the brand names of bupropion, were used as a means of helping people get off nicotine, and they still are. If you combine Wellbutrin, or bupropion, or Zyban for that matter, with a medication called Chantix. Chantix will go to the middle part of the brain at the nucleus accumbens, if I can get my brain apart here, and it will partially stimulate the nicotine receptors there. And in doing so, it'll make the brain think that you're smoking, but you're not, and it'll decrease the craving for nicotine. So the nucleus accumbens is kind of right here in the middle of the brain. This is the front part of the brain looking at you. So the middle part of the brain has the nucleus accumbens. Chantix will go right there and make the brain believe that you're smoking. And if you do smoke, it will actually block the effect of nicotine to some degree. So Chantix will release about 30% of the dopamine that you might get released from nicotine. So you get some effect there. But if you add Chantix with Wellbutrin and use that combination, you're twice as likely to come off of nicotine-based cigarettes compared to just using Chantix alone. So it's a common combination of using the Zyban or bupropion, now also known as Wellbutrin. We're using that kind of medication with the Chantix as a means of helping people get off of cigarettes. Now, there was a lot of controversy about 20 years ago with Chantix, because people would use Chantix and they'd have nightmares and they'd have these awful dreams. And retrospectively, it was realized that people on placebo in those same clinical trials where they used Zyban versus placebo, when people stopped smoking, the people on placebo had nightmares too. So it was recognized that the nightmares were part of nicotine withdrawal. It wasn't due to the Zyban itself. So that warning was actually taken off by the Food and Drug Administration years ago. So we'll often use the combination of Zyban with bupropion, not only to help you get through the nicotine withdrawal, but also to decrease the letdown you might have with depression. People wonder, with adolescents, do adolescents start smoking nicotine cigarettes because they're depressed, because they have attention deficit disorder? Are they self-medicating? Or does the nicotine actually cause them to later have those problems, especially with depression? It's now recognized that it's the nicotine that causes your brain to have more difficulty with depression later on, as opposed to adolescents self-medicating, but I'd be the first to say a lot of adolescents do self-medicate with nicotine-based cigarettes for ADHD in a lot of cases because nicotine-based cigarettes will increase dopamine in a similar manner as do the stimulants, but not as efficiently as the stimulants. So the nicotine will help to some degree. The problem with nicotine, it wears off so fast, and then you have the craving, you have to smoke another cigarette, and some people have to smoke 3 to 4 packs a day as a means of getting a nice level effect of nicotine in their system throughout the day. Now, I've been talking about smoking tobacco. You could have also been asking about smoking cannabis, marijuana smoking. Many people will use marijuana as a means of helping them sleep, helping them with aches and pains, helping them with anxiety, especially anxiety-provoking situations, social anxiety. People will use marijuana quite frequently for that purpose. The problem with marijuana, especially if you start using it prior to the age of 24 years of age, that will cause physical changes to occur in the brain where your brain just won't function as efficiently later on in life. Your brain's still growing until you're 24 years of age. If you use marijuana early on, it will probably cause you to have more anxiety, more difficulty with concentration than you ordinarily would experience. So marijuana use is commonly used for the purpose of helping with anxiety and sleep for a lot of people, but the problem is it typically makes the problem worse. I saw a young lady today who had been using marijuana since she was 15, and now she's in her late 20s, and she's using marijuana every night. Well, she can't sleep now because she's using marijuana every night, but if she doesn't use marijuana, her sleep is even worse. So we had to go with something else. And when we get people off of marijuana, the first medication we often choose to try to mimic the good effects of marijuana will be gabapentin, also known as Neurontin. Occasionally we'll use pregabalin or Lyrica, but those medications will in some ways mimic the good effect of marijuana and help with anxiety and sleep, but yet not cause the dependency and the mental impairment that marijuana will cause. Many people who use marijuana will have a slowing of their processing speed. So it's like having slow internet in your brain where things are kind of slowed down. It's so subtle people don't realize it until they get off the marijuana for at least 2 or 3 months. But it takes marijuana about 2 or 3 months to get out of your system before you can actually realize that you can think more clearly. Thanks for your email question. Let's go to our first caller for tonight. Hello, Joyce. Welcome to Matters of the Mind. Joyce, you want to know what are the most common mental health conditions that are genetic? The number one mental health condition that would be genetic would be attention deficit hyperactivity disorder. It's about 75 to 80% genetic. As a medical condition, ADHD or ADD is second only to psoriasis, the skin psoriasis condition. People with psoriasis, that's highly genetic. ADHD or ADD is second to that. So ADHD is almost as genetic as height. So if you look at family members and look at the heights, you'll see that's highly genetic. Well, that's kind of how ADHD is. So ADHD would be the number one genetic condition we see in psychiatry. Number two, I would say, is probably bipolar disorder. Bipolar disorder is considered to be about 65% genetic. It's not always going to be seen there, but it does have a strong genetic component. Number three would probably be schizophrenia. Schizophrenia, it's about 50% genetic. If you have an identical twin who has the exact same genetics as you have a 50% chance of having schizophrenia if your identical twin has schizophrenia. So it's not guaranteed. Even schizophrenia, which is highly genetic, still has that environmental component. So I'd say in order, ADHD, bipolar disorder, and schizophrenia are the three top genetic conditions that we see in psychiatry. Thanks for your call. Let's go to the next caller. Hello, Linda. Welcome to Matters of the Mind. Linda, you want to know, can antidepressant medications help with grief? I'll give you a definite maybe on that one, Linda. If you have grief that leads to giving up on life, thinking about death yourself, having trouble with appetite, getting into this clinical depression day by day where you're just devastated with functional impairment related to the grief, okay, an antidepressant medication could help you with that. It used to be thought that you should be over grief in a matter of 6 weeks to 6 months, sometime in there. You should be getting over the grief. There's different types of grief, and we realize here 3 decades later that that's not the case at all. If you have grief where you periodically lament and you're tearful about your loved one for whom you're grieving, or the grief of a loss of a situation. You should feel sad periodically, but you should still be able to sleep. You should still be able to eat, and you should still be able to get things done. If you're having trouble with sleeping, eating, or getting things done, that's where you might be crossing the line, and we call that clinical depression. That's where we would use the antidepressant medications, Linda. Now, antidepressant medications that we'd use for grief would probably be the more serotonin-based antidepressants. Many people, when they struggle with depression related to grief, they'll have difficulty with crying excessively. They'll have trouble with extreme anxiety. They'll have trouble with being able to tolerate for these frustrating situations and just getting on in life. So the serotonin medications will often give you a bit of an emotional numbing effect. Now that is not so good for some people. If you think about the pendulum, you want the pendulum to come in the middle. If the pendulum is on one side too much, you'll feel extremely anxious. You'll have difficulty with sleeping. You'll have trouble with tolerating frustrating situations. That means you're getting too little serotonin in your brain. You want to come back in the middle, but if you get too much serotonin transmission going on, you'll feel emotionally numb. You won't care about anything, and you feel kind of blah. And in those kind of situations, people don't like how they feel. So we don't want you feeling emotionally blah, but serotonin-based medications can dampen down and give you a little bit of an emotionally numbing effect. And those serotonin medications we typically use, using the trade names, it would be Lexapro, Celexa, Zoloft, Prozac, Paxil. These are all serotonin-based medications that will dampen down the emotions. Now, in the United States, those medications are often used first line for depression across the board. If you look at all the psychiatric guidelines, Lexapro, Celexa, Prozac, Zoloft especially are the medications recommended first line. But in Europe, they realized that only about 1 out of 3 people get really good benefit for depression in general with those serotonin-based medications. Then you often go to something else. So in Europe, they actually start people on medications that are serotonin and norepinephrine-based, like Cymbalta, Effexor, Prestique. Fedzima will be another one they might use. And sometimes they'll use Wellbutrin or bupropion, which I mentioned before, that will mainly affect dopamine and norepinephrine. So they won't use the serotonin-based medications first. That's kind of the practice I've used for the past 10 or 15 years, because I know that I've only got about a 1 out of 3 chance for somebody doing really well with depression in general with a serotonin-based medication. They'll feel better. They'll have less crying, a little bit less anxiety, but many people on a serotonin-based medication will have some difficulty with feeling kind of emotionally blah. They will have trouble with concentration, and they won't enjoy things so well. The serotonin-based medications will not help you so much with enjoyment, having fun, taking pleasure in your life day by day. So we'll often go with a different type of medications that affect different neurotransmitters, such as norepinephrine, dopamine. And more recently, in the past few years, we've been talking about this neurotransmitter called glutamate, which gives people more of an excitatory-based lift, and it will help with enjoyment and pleasure. Because that lack of enjoyment, Linda, will be a big, big factor on why people don't get well. If you can't enjoy things, if you don't take pleasure in things, if you can't simply, from a sensory standpoint, enjoy the world around you, if you can't enjoy social interactions, those are all predictors that you're going to stay depressed for a long period of time. And when people have difficulty with enjoyment, especially associated with grief, we'll often find that those people aren't the ones who are going to get well and get over the grief easily. So we'll want to look at the particular cluster of symptoms people are experiencing. And very importantly, I'm going to ask people, what are your main goals? If your main goal is to chill out the anxiety and just to be able to take a deep breath and look at the world around you without so much angst, by all means, you might do well with a serotonin-based medication. I saw a woman about 3 weeks ago, and I did that very thing. She had a lot of ADHD, but she did have some anxiety, and her main goal was not to improve the ADHD. It was simply to decrease the anxiety, partially associated with the ADHD, but her main goal was to just kind of calm down the anxiety so she could get through life a little bit easier that way. So I did indeed give her a medication that increased serotonin, Lexapro, and she feels better. She's calmer, and that's all she needed. That's all she wanted at this point. So if she was good with that, she can certainly stick with that. Linda, thanks for your call. Judy, you had questions about a B17 powder, and you wanted to know about these type of different type of chemicals to prevent cancer, and how about taking them for 5 years? Judy, I'm a psychiatrist, so as a psychiatrist, I deal with conditions of the brain. Now, I'll often deal with conditions that affect people in other medical ways, but I wouldn't be the best person to ask about medications or supplements that would prevent cancer. So in my field, we'll often look at other medical conditions as possible reasons why people might still not feel well. So we'll look at conditions that end up being diagnosed as sleep apnea. We'll look at conditions and symptoms that can appear to be like low thyroid. We'll look at low iron. We'll look at diabetes. And we'll look at other medical conditions, not uncommonly, because low sleep apnea, for instance, is a very, very common condition where people might snore at night. And sometimes they'll pause in their breathing. And then what they're doing is they're not exchanging airflow adequately in the lungs, and thereby getting less oxygen to the brain. If you have sleep apnea, you can be really tired. You can have trouble with poor concentration. You can actually feel depressed the next day, especially in the morning. Many people with sleep apnea will have a headache the following morning. So as a psychiatrist, yeah, I'm dealing with the brain, but I'm also looking at other conditions that can affect the brain. And if I look at these other conditions that affect the brain, yeah, I might order a sleep study, and if somebody gets diagnosed with sleep apnea, I'll certainly get them lined up with a sleep medicine clinician who can thereby get them the proper treatment for that. Same with low thyroid. I might treat low thyroid with a thyroid supplement, but if it gets too complicated and they have conditions like Hashimoto's thyroiditis or Graves' disease, by all means, those are special kind of thyroid conditions where I'm going to have them preferably see a specialist. So when we talk about oncology or cancer, yeah, it depends. You know, there are some types of cancer that we'll identify in psychiatry, but generally, I'm not one to recommend supplements to prevent cancer overall, Judy. I stand my lane on that one and refer you to the oncologist for that. Judy, thanks for your call. Let's go to our next email question. Our next email question reads, Dear Dr. Fawver, why do some birth control medications affect mental health, and what role do hormones play in teens' mental health and in mental health in general? When you talk about hormonal changes, we're talking primarily about teenage girls. Now, with teenage girls, they have the fluctuations of estrogen and progesterone, sometimes starting as soon as 9 or 10 years of age, but being very pronounced by the time they get to be 14 to 16 years of age. Now, on one hand, the premenstrual symptoms, the symptoms women can have before their periods, that can make women anxious, irritable. They can have trouble with concentration. They can have physical problems such as bloating and headache. So that can make 4 out of 5 women feel pretty miserable on those days before their periods. So that will be a factor, and adolescents will notice that. Birth control pills will stabilize out the highs and lows of progesterone and estrogen, and that can sometimes decrease the mood disturbances associated with premenstrual symptoms. Now, secondly, we'll often hear about the oral contraceptive medications being used to decrease acne, because people with severe acne also will have mental health issues, often related to their self-esteem. So the oral contraceptive medication will be there for the purpose of decreasing the fluctuation of estrogen and progesterone. Now, how about boys? Boys will have a slow increase in testosterone. It's slow and sustained. It's not as fluctuating as the estrogen and progesterone will be for the adolescent girls, but the boys will have the slow increase in testosterone, obviously given those kind of symptoms of irritability, aggression, moodiness, sometimes from that, but it's more of a day-to-day phenomenon. It's not fluctuating as much. Now, it's thought that estrogen especially will protect girls from schizophrenia. That's why the average age of onset for schizophrenia for girls is not until 24. For boys, it's 16. And that's why it's thought that estrogen might have somewhat of a protective effect. But when you have increased estrogen effects and the progesterone fluctuations like that, women will have 50% less serotonin transmission in their brains throughout their lives until they hit menopause. Then they kind of match up with men. But throughout their lives, women will have about 50% less serotonin in their brain. Thereby, they can have more anxiety disturbances such as post-traumatic stress disorder, panic disorder, social anxiety, obsessive-compulsive disorder, generalized anxiety disorder. These are all anxiety conditions related to decreased transmission of serotonin in the brain. So for a woman with a lot of anxiety, yeah, it makes sense to give her a serotonin-based medication if she has a lot of anxiety like that, keeping in mind that there's decreased serotonin in their brains in general. Now, women also will have about 20 to 30% more norepinephrine transmission than men. So women will have fluffier norepinephrine neurons. Increased norepinephrine will allow a woman to have greater self-awareness and awareness of the environment around them. Now, self-awareness, sometimes that can lead to brooding, especially if there's a serotonin disturbance there as well, and they can reflect internally excessively, and they will tend to have increased autobiographical brooding in that way, whereas men, maybe not so much. But the thing is about that is that women, by having increased norepinephrine transmission, will be more aware of their surroundings and notice things in the environment that men might miss. So there's a nice balance there for women in having increased norepinephrine transmission, but yet they have less serotonin transmission. We have to consider that as psychiatrists as we're prescribing medications selectively, looking at different symptoms on how people would respond to different medications. Thanks for your call. Let's go to our next caller. Hello, Stan. Welcome to Matters of the Mind. Stan, you want to know how to treat Parkinson's disease from a psychological perspective. Well, the first issue with Parkinson's disease, Stan, is to recognize that it's a neurologically based condition where the substantia nigra, which is a little part in the middle part of the brain, is right over here. The substantia nigra is shrinking down. That's the part of the brain that's firing out all this dopamine. With less and less dopamine being fired out from the substantia nigra, it's going down to 30%, 40%, 50% decrease. You'll have the movement disturbances where you have the tremor, you'll have the shuffling gait, you won't have much arm swing, you'll have more of a flattening appearance to your face where you won't have as much facial expression. Some people with Parkinson's disease will have gastrointestinal problems. They'll have some drooling sometimes, so they'll have more moisture in their mouths. And that's from the dopamine perspective. Now, how do we treat that from a psychiatric standpoint? The first thing I'm going to do is often look at somebody's overall awareness of their Parkinson's disease and how it's affecting them. If they're having depression, I'm going to certainly give them medications that might affect dopamine or norepinephrine. Historically, that's been bupropion or Wellbutrin, which does increase dopamine and norepinephrine to some degree. And there's nortriptyline, which has extensive study on Parkinson's disease, where nortriptyline is increasing norepinephrine transmission. So there are medications we're going to use when people have Parkinson's disease. What we do not want to do, absolutely, positively do not want to do with Parkinson's disease, is give any medication that might block dopamine transmission. Well, why would you do that? Well, there are some of the newer medications used as add-on to the antidepressants that can help with depression, such as Abilify, Vraylar, we might use Rexulti. These are all medications that can do a nice job in helping somebody boost their depression, but indirectly they can decrease dopamine transmission. That's where you want to be so careful with giving that to people who already have Parkinson's disease, because those people can have a worsening of their Parkinson's symptoms. We also want to be aware that if we give them a medication like bupropion that's increasing dopamine, we need to watch out for other medications they are taking to increase dopamine, because if you increase dopamine excessively, you can have manic symptoms where you don't need to sleep, you're more impulsive, you might buy things that you ordinarily wouldn't buy, you're more irritable. Those are symptoms of somebody having too much dopamine transmission, so you can go the other extreme. So the treatment with Parkinson's is where you get this nice balance of getting just enough dopamine transmission to help with smooth movements, but yet not cause manic behaviors and irritability and decreased sleep. Stan, thanks for your call. Do we have another call? Yeah, we do have another call. The next caller is asking, here it is, Harper. Harper's asking, if you don't know how to describe your symptoms, will a psychiatrist still be able to see you? Harper, you're wondering if you can't really describe what's going on with you, could a psychiatrist still evaluate you? I think we could. Several things we can do, Harper. We can give you time to think about your symptoms and give you different questions that might provoke your ability to describe them. For instance, in my practice, we will give people a lot of questionnaires, and we give them a lot of questionnaires before that first evaluation, because I want to ask us all these different questions about anxiety, depression, sleep. I want to know what kind of physical symptoms they're having. I want to know if they've had any past traumatic experiences. Are those traumatic experiences affecting them now? So we can ask you all these questionnaires that can kind of search out what kind of symptoms you're having. And those questionnaires will give us a lot of ideas on what direction to go for you. So even though you might not spontaneously be able to describe what's going on for you, Yeah, if we give you a few questionnaires, that's kind of an icebreaker to help us kind of get an understanding of what direction we need to go for you. But a psychiatrist will still see you if you don't know how to describe your symptoms, as long as you perceive, Harper, that you're having some kind of emotional or mood or thinking disturbance that is affecting your day-to-day life. In other words, you have to have some kind of brain symptom disturbance that's affecting your ability to socialize, to go to work, to be able to go to school, to be able to have a normal life. And very importantly, Harper, if you can't describe your symptoms, I bet you have family members, friends, people who are around you in your day-to-day life who can probably describe how you're being how your day-to-day life is being disrupted by your overall mood or your ability to think. So if you can't describe those symptoms, friends or colleagues or family members often can. So it's not uncommon that I will ask for a family member to join me. We do a lot of telehealth, and family members often will join a person on telehealth and kind of give me some extra ideas on how a person is doing, and that's very, very helpful. Harper, thanks for your call. Unfortunately, I'm out of time for this evening. If you have any questions concerning mental health issues that I can answer on the air, you may write me via the internet at Matters of the Mind, all one word, at WFWA.org. God willing and PBS willing, I'll be back next week. I'm psychiatrist Jay Fawver, and this program is also available on YouTube. Thank you for watching. Have a good evening. Good night.
The preceding program on PBS Fort Wayne was made possible in part by
Cameron Psychiatry, providing counseling and care for those that may struggle with emotional and behavioral challenges. More information available at CameronMCH.com.